I'm not talking with you with a very deep science, but I will share with you our experience when we face a problem that we had, everybody, the last 2 years, in not only my hospital, but many hospitals in the world. And COVID-19 was the first new international crisis that was due to an infection after HIV. And as you know, we had some problem. It started with something like prison and death. This is after we decided it was called a pandemic or a large outbreak. And we'll see a little bit here some selection of health crises due to infectious diseases. It is not recent, as you know. We had the Black Death that was due to plague. A long time ago, 100 million people, about 1/4 of humanity, died because of the Black Death. And after, we know we had many others. And I share a little bit with you. We had smallpox. You know that is something very important because smallpox disappeared, is supposed to be disappeared. And many others with the Spanish flu that is now very famous because we compare COVID-19 with Spanish flu. And Spanish flu killed about 25 million people in the world. And we have tuberculosis, TB. TB is killing 1 million people a year currently. Yeah, it's not something new. And COVID-19 is around 6 and 7 million people recognized, and probably at least twice more in the world that we face. The mechanism of transmission of these different infectious diseases is very different, is very various. You have mosquitoes. Malaria is very famous, and we are talking now about mosquitoes and about what is coming to France with the new mosquitoes coming from the south because of the environment crisis. Smallpox was transmitted from patient to patients, and this is why we could eradicate a smallpox, because if you stop the transmission between patients, you stop it. But when you have rats, fleas, like the Black Death, you cannot monitor it. It's more difficult. And cholera is transmitted through water and so. And what is interesting is that 3 of the most deathful pandemics are transmitted by aerosols or airborne transmission. 3 of these. So that's why I'm going, and we are interested in aerosol transmission of infectious diseases now. This is not new. Tuberculosis, for instance, is very well known, and it has been demonstrated in 1959 that aerosol is a mechanism of transmission of TB. So this is not something new, and the problem is what did we about this since that time? TB has killed, in the last 30 years, 50 million people. So COVID is like nothing, okay? And if we take from the beginning, probably TB has killed more than 100 million people. And transmission by aerosol, we did nothing. Why? Because we are rich, and we have no more TB in rich countries. And the transmission is still occurring in the remote country, in the country from the south. If we talk now from something more modern, SARS, the SARS-CoV-2 or COVID-19, it has been shown from the beginning that the aerosol transmission may be key to stop COVID-19. For instance, in this publication, we had a choir, it's difficult to say for me, a choir, so they are singing all together. And you put someone with COVID-19 here. And this guy is, of course, there is contamination. And that this guy is contamination, people very close from here. It's not surprising. But in that publication, they found other people at the distance of the group that were contaminated, and there were no other social relationship between these people from the one side and the other side. And so the transmission by airborne transmission was highly suspected for COVID-19 from that time. And there are many other examples like this. If we go in a hospital now, for instance, from the study in Italy, they show that they could find some viral RNA at a distance far from the patient. So the virus has probably traveled through the room, from the patient through the room, and is still there. The question, of course, was always, yes, okay, but the virus may not be infectious, so who cares about finding RNA and not a live virus that is alive? Okay, we tried to do something else. And people have took some ferrets in 2 different places, and the only way they can communicate was by the transmission of air flux. And they have demonstrated exactly the same experience that was used 50, 60 years ago to demonstrate that TB was airborne. And here, the ferret on the top was contaminated by the ferrets on the bottom. So, obviously, there is airborne transmission with infectious particles that can travel through the air for the COVID-19. And so the story started, as you know, for COVID-19 in November 19, with the first case in China. In the beginning of 2020, it was called a public health emergency. And in March, the outbreak was called a pandemic. What we did from there? We waited for 1 year, and we had evidence that CDC and WHO said that, okay, maybe COVID-19 can be probably transmitted by airborne particles. Maybe. But we had many, many, many data to say that, yes, it is. It's not probably. We have data now. And what we did? Nothing. Look at you. Who has a mask? You are all confident in the ventilation of this room? Yeah, cool. How can we prevent airborne transmission in the hospital? In the hospital, in fact, we have divided the different places in the hospital in 4 risk zones. And the measure to prevent airborne transmission is only in a small part of the hospital, the zone 4. Oops, sorry, of course. Wrong. The zone 4, where you have surgery, or you have a cancer patient, an hematology patient with high filtration in the room. But in other places, like waiting room, you are waiting for your consultation, like hospitalization room, almost no. Why? Because the regulation in France is not based on prevention of airborne infectious disease. It's on pollutants, it's on temperature, humidity, but that's it. Okay? We do indirect control only in very special area in the hospitals. The problem is that most of the patients are in the area where there are no control of the infection in the air. And what's happened when you have a patient that is arriving with a very infectious disease that can be airborne transmitted? You have this patient that is coming. It's very simple. We are rich, and in our hospital, we have a special room with negative pressure to put the patient. No problem. In my hospital, we have 7 rooms like that in the infectious disease unit and 2 in the ICU, so we don't care. It's very easy. And the prevention that we use in the other part, say, okay, when you enter, you have fever and so on, you should do triage of the patient first. Suspicion of infectious disease, you put them on the side. Second, you isolate them. And third, you put a mask. This is what happened at the beginning of the COVID-19. This is what we do for TB or for other infectious disease, like a patient coming from the south and that is suspected of SARS-1 or Ebola and so on. But COVID-19 was another story. We did not have 1, 5, or 10. We had thousands of people coming in the door of the hospital with suspicion of infections. And what are you doing now here in the waiting room? All these people are contagious. So your single or maybe 7 isolation room are not worthy. You cannot use it because all the hospital is full. So you say, okay, we don't care, all the hospital is full. But this is not what we think. So first, don't panic, sit down and think about what to do. And what they did, and what we did, we stopped the world. Lockdown. It reminds me from the Black Death 20 centuries ago. This is what they did, if you see the history. And what they do, for instance, for TB, in countries where there are a lot of patients for TB, they say, okay, let's be smart. Don't put people in closed room, let them stay and wait for the consultation outside. At least there's some fresh air. And this is something very smart. You cannot do that in Kazakhstan, because Kazakhstan, during the winter, it's a little bit cold. So you have to think about other means of preventions. And what we did in France is you isolate people, you do masking, you wash your hands, you do the triage on admission, you say, okay, I decided that the second floor is for the contagious people and all the other one is for non-contagious people. And we did test and vaccination. But with many, many people, we stopped, in fact, the hospital. And many questions were not addressed with this traditional prevention of airborne transmission. We had many questions about, first, is it safe to mix contagious and non-contagious patients in the same ward? Because if it is, it will be very simple for us. The life will be easy. But we are very anxious because we know and we have data that there is airborne transmission when you open the door. And what happened with the other patient in the other door? Is it smart to open the window? Because when you open the window, the fresh air and the contaminated air is going to the hallway and in the room in front or on the other side, because it follows the airflux. Is there an increased risk of transmission with non-invasive or invasive respiratory support? In fact, in ICU, a lot of COVID-19 patients were in ICU, and we were very anxious about transmission in ICU because you do a lot of respiratory maneuvers that can be highly contagious. So what should we do? Is there a different prevention method that we should apply in these places compared to other places? And the operating room. By definition, an operating room is what? Positive pressure. Everything should go out of the operating room. No air should enter. So if you do an operation in a COVID-19, a contagious patient, or you have a surgeon that is positive, the air is going outside and probably in many other places. So should we stop the ventilation? Should we stop doing surgery in contagious patients? When you have one, you can say yes. When you have thousands, you can say no. So what